McMullen.
Hello, this is Dr. Robert McMullen. I'm a psychiatrist, and I've been in practice over 30 years, specializing in psychopharmacology and now also in TMS, transcranial magnetic stimulation. I went to Georgetown Medical School, which was a fabulous place, and I did my residency at Columbia Presbyterian, which was also a very nice place. Very good experiences. And I want to talk about an unusual case I had of someone who had a rare disorder that I never heard of. Plus, she had some other things that are much more common, but that were also really problematic for her. This woman was in her late 20s, and she had what is called Pgad, paroxysmal genital arousal disorder. And what it is having spontaneous orgasms during the day for no apparent reason, but sometimes some stimulation. Like if you're driving your car and you hit a bump, then she might have an orgasm there. Now this is an extremely embarrassing disorder to have. Especially doctors might make a joke and say, well, it's better than not having any orgasms or something like that. It's, the women who have this have a very hard time with doctors. And it's really actually unpleasant. Some people call it more like a pain syndrome. And she said it's a little bit like feeling like you have to sneeze but can't. And it's going on all day long. Now, in addition to this, she had chronic pelvic pain that seemed to be like a combination of a few different disorders like cystitis or vulvulitis, and had been receiving injections in the pelvic floor for this. Interstitial cystitis is the word I meant. And she also had chronic depression and just massive amounts of anxiety. And she supposedly had a learning disability because she always had tutors since she was in elementary school. However, she seemed really quite intelligent. And I soon realized that she was having rapid cycling depressions. Now it was rapid cycling in the sense that she's chronically depressed and anxious, but sometimes her thoughts would race and she'd get hyper and her thoughts would be racing for 5 minutes or 10 minutes. There was no euphoria, not a feeling of being high, but an experience of being agitated and wired and speedy, and you could tell it talking to her too that this was happening. And then 10 minutes later or an hour later, she might be more profoundly depressed in a sedated, negative way with motor retardation a little bit. But she was constantly cycling like this. And then as I began treating her with TMS, which I'll get to in a minute, and as I began treating her, I began realizing that there's constant ruminating about things in the past that she felt guilty about, and she couldn't stop thinking about them, even though, these weren't really terrible things. She was a very good person. She'd never done anything bad, and she was actually a very generous-hearted person who was concerned about other people, but had been in some friction with her family, partly because she had been so dysfunctional with all this depression and anxiety and everything else. So what I did was I treated her, because I thought there was this bipolarity. I didn't want to do the standard excitatory treatment with TMS on this left forehead. It's called the dorsolateral prefrontal cortex. I treated with an inhibitory treatment on the right dorsolateral prefrontal cortex. And then the way you calculate where you treat, there's two different ways. And I won't go into them. One's calculated by where you would place the EEG, and the other one has to do with finding the hot spot for the motor threshold and going 6 centimeters anterior. Well, it doesn't matter, but the two different ways of finding it were really quite far apart, like about 3 centimeters apart, which is unusual. So I just decided to treat both places, because if I treated one or even one in between, maybe I wouldn't be hitting the right place. So I treated both places with an inhibitory treatment that I use theta burst, which only takes 40 seconds. It's a special type of pulse. But anyway, I treated those two places. And then I treated for pain on the motor strip where the representation is for the hips. And I thought that this might help with her chronic pelvic pain. She was always sitting on a pillow, and maybe it would help the Pgad. And sure enough, gradually the pain was improving, and then I was beginning to realize that there was a OCD component, this obsessive compulsive disorder, which really might have been a separate disorder. It's hard to tell. And so then I began treating on what's called the pre-SMA, the pre-supplementary motor area, which I believe is about 3.5 centimeters or 4 centimeters anterior to the vertex. I'm not sure exactly now. But in any case, I began treating there. So we were treating 5 different places. And we did over 75 treatments. And sometimes we would treat 75 sessions. So she got well over 300 treatments, since there were at least 5 treatments, at least 4 or 5 treatments in each session. But sometimes we would have her wait around since she had a long ways to drive, and an hour later, we'd just do another one, another session. So she had so about halfway through, I believe, the spontaneous orgasms stopped. They went down to just normal. And the pain went away. And then very gradually, the depression got better and better, and the anxiety. And one day she came in and she sat down, and I realized within 10 seconds that she was not depressed. And she said she's not depressed. It's gone, completely gone. And then on the scales, so we have like a Madras scale. There's 2 self-rated scales, and then a scale that I do, and on those she came out well below 5. So she really came down to completely normal, and she stayed like that for several months, and then for complicated reasons, she's not, which I don't want to go into, she's not on quite the medication I think she should be on for depression. So now it's a few years later, and she does have some chronic, mild depression, or maybe a little worse than mild, I'm not sure. But the pain has not come back. The OCD has not come back. She's not rapid cycling. The Pgad is in remission, and she's functioning. She's working full time, and you would never know that there's a problem, because she's a cheerful, animated person. I wish I could change things around, but I can't, to get rid of the depression completely. Another way to get rid of the depression completely is sometimes just doing some more TMS treatments. Once you've had a remission from it, you don't have to do another 75 sessions or another 30 or 20. Sometimes you just need 5 or 6 sessions. But that was a remarkable case, and we have quite a few people that have been chronically depressed all their lives, never felt normal, and with TMS for the first time in their life, they not only feel normal, but they don't relapse for 3 years or so. And I'm about to see somebody soon this evening. I haven't seen him in a while, and he was one of the first patients we treated 7 years ago. and he'd been depressed all his life, 60-year-old man, and a physician, and really painful depression all his life, and with a total of 50 treatments, he felt completely normal, and he did well for 3 or 4 years, and it's hard to tell when, but a year or two ago he started very gradually to go downhill, and so he's come back to get some touch-up treatments to bring him out of it. But it's just astonishing to have somebody who's been depressed all their life become normal and then not relapse for a few years. They're still on medicine, but it's the same medicine. It's just working 100% instead of 80%.
And it's helped this woman with her
Pgad, yeah, it helped her. That never came back.
The TMS helped her.
With the TMS. And so I published that case. And I've got a few other cases that I'm going to publish on some other problems that we've done. And we have a paper in on treating depression in people who are bipolar. We've got that paper has been submitted for publication. We hope to have that published soon.
Thank you very much, Doctor.